malignant glioma, the whole field has actually sort of gone into warp speed in the last few years in terms of therapy, in terms of pathology, et cetera, and biology. So I'm going to spend the first part of the talk on definitions, biology, and then I'm going to kind of go through the clinical aspects, and then kind of finish with some of the therapeutic options that are on the frontier in terms of research. So about 20,000 cases occur of malignant glioma a year, slightly increasing incidence per year, high mortality rate for glioblastoma, median survival somewhere between 12 and 18 months now. Glioblastoma, we don't call it multiforme anymore, just FYI. It's called glioblastoma. It accounts for about 2/3 of the malignant gliomas, the others being anaplastic astrocytomas, anaplastic oligodendrogliomas. They're more common in men than women, and they're twice as common in Caucasians than non-whites, which I think is something quite interesting. And one thing that's always been intriguing to me is the patients have a profound T-cell dysfunction the minute they come in off the street, and we're going to talk about that a little bit more. Interestingly, malignant gliomas arise primarily in the frontal and temporal lobes, and we've always known that, but I think recent research kind of lends more information as to why that is, and I'll get to that in a minute. In terms of years of productivity lost due to cancer, they're one of the top 5 because they often do strike young people. There are glioblastomas in pediatric patients, and since it's highly fatal in young people, it can end up causing a huge loss of productivity and future life loss. What's the cause? Well, we know there are certain cases like, unfortunately, I just operated on a lady last week who grew up in the shadow of Chernobyl, and we know that ionizing radiation can be associated with risk of glioma. Huge studies in Sweden looking at familial links have shown that there are some familial glioma patterns, but then when you dive down genetically, you only find that maybe a fraction of a fraction of a fraction of these have a gene mutation. There's one gene called POT1 that's been associated with telomeres, and as any of you who know about cancer biology, you know that telomerase is a critical gene involved in maintenance of cell integrity. My group has been studying for about 15, 20 years the possibility of a, I didn't realize I was not on this. My group has been studying for about 15 years the association of CMV with malignant gliomas, and it's been kind of a controversial field, but I believe we're poised to make some interesting discoveries in the next year or so that may provide much more information about what's going on. We just got a paper accepted, my colleagues at Brigham and Women's and I, showing in a mouse model of CMV infection in mice with gliomas that the tumors are driven much more into an aggressive phenotype. The mice die much more rapidly, and we're figuring out some of the molecular pathways involved, which seem to correlate with what we see in humans. So when I got into this field about 15 years ago, 20 years ago, we knew that glioblastomas arose sort of in 2 flavors, basically what we called primary gliomas and secondary gliomas. Primary gliomas are those that arise in older people, and they're the ones we typically see. A 65-year-old comes in and they've got a glioblastoma. Secondary glioblastomas are tumors, not sure if this guy's working, but are glioblastomas that arise from lower grade tumors. And we knew that there were some genetic differences in these, but that's about the extent of it until 2008, when a big paper published on a huge study from the tumor consortium TCGA database looking at genetics and RNA expression, and they basically showed that glioblastomas arise due to genetic defects that either affect the driver or the accelerator or the brakes. And if I get this pointer to work, it'd be good. But bottom line is most of these tumors overexpress cell surface proteins like EGFR, which provide sustained signaling downstream to promote proliferation, and simultaneously deletions in one of the genes called CDKN2A, which is a gene that sort of overrides both the RB and P53 tumor suppressor pathways. So once you get early hits in these pathways, you've sort of lost the fundamental regulation of the cell proliferation, and then cells go on to acquire other mutations. And then sort of a secondary analysis showed that these will break down into sort of categories called proneural, neural, classical, and mesenchymal. And if you look at the genetics involved in these, the proneural kind of stands out because most of these are associated with P53 mutations and this newly discovered thing about 10 years ago called IDH1 mutations. And most of these also have PDGFR alpha amplifications. Those patients seem to have a much better prognosis. At the time, we didn't really understand why that was, but that was the state of the art 10 years ago. Fortunately, we've learned more. Actually, our group here at the Ivy Center with the Allen Brain Institute had a paper last year that sort of dives deeper into what those molecular classifications are. And it turns out, for the most part, the predominance of certain characteristic features of the histology will determine what the overall genetic sort of classification is. In other words, if you have a lot more areas of pseudopalsading areas of necrosis, that would be more mesenchymal. But still, this proneural group stood outside. And that is primarily now what we know to be due to what I would call a major discovery in terms of our thinking about gliomas, which is related to the IDH1 mutation. So IDH1 is an enzyme in the Krebs cycle, isocitrate dehydrogenase. And this seems to be a sort of first event that happens in the so-called secondary glioblastomas, which are those that arise in younger people and go from lower grade to higher grade. And so why does this mutation lend itself to a less aggressive tumor? It turns out that if you mutate this gene, then you have a subsequent downstream buildup of 2-hydroxyglutarate, and this will mess up the methylation of the histones, and you'll get a hypermethylation phenotype. So you'll methylate all these nucleotides, and this will cause the so-called CpG methylator phenotype, or SIMP. And what this lends itself to is epigenetic events that promote transformation in malignancy, but at a slower rate than the de novo glioblastomas. Kind of a little counterintuitive. So now we lump gliomas into this molecular kind of concept, which is we think the tumors start as cells with some kind of stem-like phenotype. Ooh, and help me. And the cell at this point will either have a bunch of early mutations that lead to the primary glioblastoma. Thank you. Great. Does that work?
It's the top button.
The top button. Okay. Yeah. So most of the glioblastomas we see just start out from here and go whoop right to here, and you got a glioblastoma. We now know that the lower grade tumors in younger people start with the IDH1 mutation, and then if they go in one direction with a 1p19q co-deletion, they'll be oligodendrogliomas. If they go in this direction, they'll be more astrocytic and low-grade astrocytomas and anaplastic astrocytomas. So these guys take longer to get to the glioblastoma stage. And actually, we no longer call these highly malignant oligodendrogliomas glioblastomas if they just stay in the anaplastic oligodendroglioma category. And you know, this is a paper that's about 10 years old, but it goes back to the original picture that I showed that you didn't see because I didn't have it on the screen, obviously, that shows most glioblastomas arise in the frontal and temporal lobes. And I think now we have an understanding of why that may be occurring, which is that if you look at the location of the neuroglial precursor cells, they tend to be mostly in the frontal and temporal subventricular zones in the brain. And these are the cell of origin, we believe, of gliomas. So what the hypothesis is these neuroglial precursor cells differentiate into neural or glial precursors, probably along this pathway, and at some for some reason at this stage they become transformed. There's a subset of cells that stay in this stem-like capacity, and they pump out daughter tumor cells, which go on to be glioblastoma cells. And this is another way of showing that these neural precursors, glial cells, get transformed, and these brain tumor stem cells sort of stay in a state where they self-renew and then pump out daughter cells. And these cells are what we have a couple of clinical trials going on for in the Ivy Center, because they are the most robust cells that seem to survive despite radiation and chemotherapy. They're known to have high motility, robust proliferative potential, and resistance to chemo and radiation, as I mentioned. And they're characterized by certain markers like Nestin, CXCR4, on CD133. And we use this marker sometime to sort them out of tumors in our lab. And a paper came out last fall that was quite interesting by a Korean group that I think confirms pretty much this concept that the cells in the subventricular zone probably get initial mutations, and then they turn into these brain tumor stem cells, which are highly migratory, and they go out in that location and then pump out daughter tumor cells. So this group biopsied cells from here and biopsied cells in the normal brain surrounding the ventricle. And then they did genetic analysis, and they found that, in this group of tumor cells, you might have, 100 mutations here. And in this group of cells here, they interestingly found that some of them had about 5 to 10 mutations. And it turned out those conserved mutations were the driver mutations, the P53, the telomerase, and others that are known to be associated with the first hits. So the other mutations may be sort of downstream irrelevant mutations or sort of passenger mutations. But it kind of fundamentally helps us understand that these tumors arise from subependymal ventricular zone stem-like cells that are transformed and then migrate into that area. Another key concept of these tumors is that has been, I think, overlooked until recently, but it's been known for 50 years, is the patients with malignant gliomas are immunocompromised. I remember in medical school, we had a professor who said that patients with glioblastomas would be anergic when you give them a skin test for Candida. So that's just sort of the basic test to see if T cells can migrate and function. So for whatever reason, these patients have T cell deficiencies, and we know a lot more about that now. We know that their tumors are often secreting TGF-beta, IL-10, PGE2, and that their tumors are associated with high levels of regulatory T cells that are characterized by these markers that are immunosuppressive. And if you look at the patient's CD4 counts, they're often at the level of an AIDS patient the minute they walk in off the street. The average CD4 count of a glioblastoma patient is in the range of 200, which is striking. And this sort of illustrates what happens when these tumor cells are pumping out all these immunosuppressive molecules. They cause downregulation of MHC class 1. They induce the expression on circulating T cells of the suppressive markers CTLA4 and PD1, which we know are now major targets of the immunotherapy. They alter the function of dendritic cells, preventing them from maturing. They alter the function of macrophages, keeping them in the M2 phenotype, which is the more tumor promoting as opposed to tumor anti-tumor response, and alterations of microglial cells. So I'm going to switch gears now and talk about clinical care of these patients and why we do what we do. And I'm trying to make it as data-based, data-driven as I can. I've had the opportunity to be on a few of these national guideline committees, and it's amazing when you drill down on things and look at the data, what we do and how we do and why we do it. The most important thing about these patients is prolonging their survival and quality of life. And they present with the typical symptoms you would imagine, typical focal neurological deficits and seizures. And when they arrive in our clinic, we have to take the whole broad picture of sort of the humanistic view of what the goal is. We had a consult yesterday on a patient who's elderly, is now hemiplegic, and now is demented, has recurrent tumor, it's multifocal. There was a question of surgery, and no, this is not what we want to do. Even though we could take this tumor out, why would we do that? So we want to extend survival and quality of life without harming the patient, and we have this sort of armamentarium of techniques and things we can use, but we have to take it all in with the big picture of what we're dealing with. The most important factor in terms of prognosis is age. Now we know that age factor is really a molecular determinant. It's the IDH1 mutated phenotype, which I mentioned earlier, which those patients do better because they have a different biological beast that we're dealing with. But of course, we take the Karnofsky performance scale, and then we have to know, what's the benefit of surgical resection. When I started in this field, my chairman at UAB was nihilistic. He said, biopsy him, send him out. It's a death sentence. We know that's not the case now. But, in the 70s, before some of these therapies, the one-year survival rate was about 3% for glioblastoma. Then chemotherapy bumped it up to 12%. And then radiation was an 8-fold increase to 24%. So radiation is really the primary modality of improving survival in these patients, although I would, again, argue in a minute that surgery, we think, does help more than we used to think. And then we have all these other prognostic markers, and this is a major one that I'll talk about in a minute, MGMT and IDH1, obviously. A good paper was put together by colleagues of mine a few years back that talked about, what does the typical person do? Most of the time we get it right, taking care of these patients. 92% get an MRI, most get an attempted resection, some people get cortical mapping during surgery. Some of the things we don't do right are almost 90% received anti-epileptic drugs, and actually the Academy of Neurology did a prospective randomized study, and this was really in the era of Dilantin with more side effects than Keppra, but showed we don't really need to be giving everybody anticonvulsant who has a glioblastoma because some of these patients will never seize, and it's probably not a benefit to them unless they've had a seizure. The same applies for metastatic tumors. We do a bad job of treating their depression. A lot of these patients get depressed, and we do a bad job, at least then, of prophylactic low molecular weight heparin post-op because these patients do have one of the highest level of DVT for all cancer types. In terms of anti-epileptics, most people got Dilantin in the old days. Now most people get Keppra because it's non-enzyme activating for the liver. I pretty much give Keppra to patients who have tumors that are large and have a lot of mass effect where a seizure could make them herniate, or if it's in the temporal lobe in a sort of hyper-epileptogenic area, but a little focal frontal GBM, I don't typically put patients on anticonvulsants. It's sort of a knee-jerk reflex for some of the anesthesiologists who load them even without us asking. But, I think in the age of Keppra, it's probably okay to put more people on it, but it's still kind of debatable. What about imaging? There are, recommendations based on guidelines. Obviously, everybody gets an MRI with contrast. I think she keeps wanting me to get on the web. But the guidelines are not, there haven't been too many prospective randomized studies other than for this. But, more and more we're putting more emphasis on gadolinium-enhanced MRI, plus all these other modalities that help us sort of get an estimation of what we're dealing with. Briefly, I'll just say CT is not that helpful other than screening someone who comes to the ER with a focal neurological deficit. But sometimes, for instance, in an oligodendroglioma, you'll see calcification in a lobar tumor. That's kind of a hallmark of oligodendroglioma. But most of the time what we use is the MR with T1 gadolinium. And we see, assess where the tumor is, how big it is, the mass effect, if it's infiltrative, if it's multifocal, and use all this information to start planning what we're going to do. I mean, if I see this patient who comes in with a seizure, I'm thinking right frontal glioblastoma, I want to take it out, plus I want to take out a centimeter around it. or more. This patient comes in, right hemiparesis or a little bit of weakness. You're dealing with something right on the motor cortex. Is it worth resecting at all? What about a biopsy and just getting them onto treatment? Some of the caveats and other modalities include relative cerebral blood volume. We're using this a lot here. This helps to look, for instance, this is a glioblastoma, and this area is very hypercellular and very hot on cerebral blood volume, indicating a very aggressive tumor growth in this non-enhancing region. And we get these performed on many of our patients. Diffusion coefficients, there's low diffusion in some of these very malignant areas of tumors. So the ADC, or the apparent diffusion coefficient, would be lower in a highly malignant tumor, and that's helpful. And then this is kind of a paper that sort of summarizes putting everything together. So if you look at all these different tumors, you can kind of figure out what's the likelihood of something being more aggressive than not, even if they all look, maybe they look similar on T2 weighted imaging. You may have a tumor that's on T2 is bright, and then, it's maybe non-enhancing, but maybe there's low ADC and high cerebral blood volume, and these would all be prognosticators for bad outcome. And if you line up these things, you can see that this is a high-grade glioma with a high cerebral blood volume. They're going to do worse than people with low cerebral blood volume in their tumor. And sort of consistent with that, with the ADC, if there's low diffusion, they're going to do worse than people with less restricted diffusion. We just use all this as sort of taking into account what's going on up front and with recurrent tumor. We don't use PET that often, but it can be very helpful. I mean, if you're screening for METs or something and you see this in the brain, obviously that's a positive case. But here's a good, interesting case, like a patient maybe has a tiny GBM here, and the PET is really hot. It stands out. That would indicate you're dealing with tumor. This patient went on to get treatment, and then they got radiation necrosis, and then you get another PET, and it's not as hot, so it can tell you, well, this is probably just necrotic tissue and not active tumor. In this case, a post-operative patient, status post-radiation chemo, has some flare signal change. Is that just from radiation? And now on the PET, you see that, so you're pretty convinced that that's active tumor regrowth. The other things that are sort of esoteric nuances that you have to know about these days is pseudoprogression, which is if you get a glioblastoma resection and you radiate temozolomide, you may get areas of enhancement that are not actually tumor. They may be just the radiation effect, and then over time, like in this case, it looks like the tumor's recurring, and then if you follow it, it just is areas of radiation necrosis. So that's called pseudoprogression. And the flip.
Pseudoprogression peak?
When does it peak? Probably about 9 months. Let me see, do they have a timeline here? Yeah, probably around, I don't know, a few months, I'm not sure. The flip side to that became apparent when we started giving people bevacizumab or Avastin, which is a antibody to vascular endothelial growth factor, VEGF, which previously was called vascular permeability factor. So it's basically like steroids on steroids. It shuts down all the microcapillaries. So you can have a GBM with enhancement, give bevacizumab, and the next day it looks like this, and you're like, wow, the tumor's gone. Well, not really. That's pseudo-response because you've shut down the leaky blood vessels, but you haven't cured the cancer, and there are actually some studies that show that actually changes the biology of the tumor cells, and then they learn how to grow without oxygen. When we're thinking about surgery, we often will do all these kind of studies and then pre-plan, and especially if patients have tumors that are near the motor cortex or in the dominant hemisphere, we may do functional MRI, and that's something we do on our patients to try to figure out where Wernicke's and Broca's areas are. If you have a big tumor like this and they show you that, the Broca's area has been shoved down here and motor's up here, you could still consider resecting a lot of that tumor, but you might want to do it with stereotactic guidance and the patient awake. And almost universally now, people do use frameless stereotaxis with Stealth or Brain Lab or one of these modalities where you have infrared probes in surgery that are downloaded on the MRI, and the patient's conformity on intraoperatively is put on there so you can point to different spots. And then you can overlay some of these other things and use DTI, which is tractography, to overlay the corticospinal tracts and all these things. So while you're operating, you can get an idea of where a tumor might be in relation to some of these pathways. And then when you pull all this together, you can, have a better idea where you are intraoperatively during the surgery. Although sometimes the brain will shift. If you're taking out a big tumor, it might flop over, so then all this preoperative planning is not helpful. And you can use something like intraoperative ultrasound, which is probably way underutilized for its benefit, which could be helpful in finding like a local area to resect. I'm just kind of showing you everything that we have at our disposal. One thing that's coming on board as FDA approved technique, which has been around for about 10 or 15 years, primarily in Europe, is one of the amino acids associated with hemoglobin, 5-aminolevulinic acid. If you inject this IV, it will go into areas of infiltrative glioma. And then if you turn on a UV light on the microscope in the operating room, you'll see fluorescence like that, where there are glioma cells. And this technique is becoming more and more useful for people who really want to push the envelope in terms of the ability to resect as much of the tumor as possible. I'm not going to really go into this, but another technology that's just on the forefront is Raman Spectroscopy, where you can actually have a probe in the tumor that can say if something is more white matter-ish or more tumor-ish, and that may be something we use in the future as well. There's nothing better in my mind, though, than an awake patient when you're operating and trying to tell if something's working or not. We operated on a lady the other day, and we just were talking on and on about, her background in dance and all this stuff, and she's moving her arm, and you're pretty confident everything's going well if they're talking to you during the surgery. The second best thing is mapping while they're asleep. So you can put a little strip electrode. This is what they look like. In the operating room, we slide them up over the motor and sensory cortex, and you'll see a reverse in sensory and motor pathways. It's called phase reversals. If you're like operating here or right here, and they say on this, between this guy and this guy, you got phase reversal, then you'll know that you're down here, and that's up here, and that's sensory, and that's motor. So that's one of the techniques we use to locate motor. Another one is just using the Ogeman stimulator, where we touch the brain, and with a patient not under paralytics, you can stimulate up to, starting at low amplitude, low amperage, and you can get motor effects if you're in the motor cortex, and you can actually map out the whole primary motor cortex. For speech, you can't really do anything unless they're awake, but if the equivalent motor area of speech would be Broca's area, up here on the left frontal area. You can have patients read things like, this is a picture of that, this is this, and then you stimulate at Broca's and they go, bleh. So you're at Broca's area. And that's something we do. And then if you can map out Broca's area, you know that if you're about a centimeter or two away, you're probably safe for resection. So this is just a kind of a picture of how you can do all this mapping. You can map out different areas, and you can see where you are on the Stealth or Brain Lab navigation, so you know your location. And this is a picture of how we do it in the OR. As I mentioned, I operated on a lady Friday who had a tumor that was presented with some speech difficulty. The tumor was right in this location here, and I was concerned that it may have been abutting the arcuate fasciculus, where the tracks from the Wernicke's go to Broca's. And so we, opened her up and then woke her up and started talking, and boy, she was a talker. And, but that's great, she was talking all about her ballet and this and that, and we're just taking out the tumor. We got the whole tumor out, and she, she didn't have an endotracheal tube. She just had an, oxygen and sedation, and they do great. They she went home the next day, tumors resected, and they do quite well. This is a picture of an MRI of a patient that was sent to me from some outlying hospital, lady who's like 70 years old, and they said, she's got a GBM, it's right in the motor cortex. She presented with a seizure, there's nothing to do. And I saw her, and they said it was inoperable. So, you look at it and you're like, okay, well, that's probably motor. So it's like right behind motor, and there's sensory, and so it's jammed right between them and the central sulcus. But I said, let's just, if we take this thing out safely, then you might actually survive longer than if we don't. Really sweet lady. So we took her. I did have a video of this, but it's not working. But so here it is. It's right side. That's the midline. That's the dura, and the sagittal sinus is here. So that's the motor strip. So we took this. We're taking the tumor out, and while we're taking the tumor out, she's awake, and we're saying, squeeze my hand. There's the anesthesiologist's hand, squeezing the left hand, doing the surgery. She's talking, and I'm just taking the tumor out. There's motor here, and got the whole thing out. As you can see on this post-op scan, I was able to resect the whole thing. And then here she is post-op day one, sitting up, talking, doing great, opening and closing her hand. She actually lived, for someone in her 70s, I think she lived like 2 years, which is dramatically more than I think she could have. So I think we did benefit her by pushing the envelope. So that leads sort of one of the critical questions of the naysayers versus the more aggressive surgeons. And, I try to be, circumspect and not, data-driven. Certainly there are cases where you're going to operate. If there's a huge tumor, mass effect, they're going to herniate. You need to take it out, just like if it's a blood clot. It's a little less clear if there's a deep small lesion in the basal ganglia or something. Obviously in those cases I prefer just a biopsy. But in most other cases where the tumor is accessible and could be safely resected, I think it makes sense to try to be aggressive. And this has never been proven with a prospective randomized controlled study, because no one's going to say, okay, Mr. Jones, you're going to get a total resection. Over here, you're going to get a biopsy. We actually do have something like that for low-grade gliomas, which occurred in Norway, because if you are in this half of Norway, you got a biopsy for low-grade glioma. If you were in this half of Norway, you went to a center where they resected it, and they showed that the survival was double for those that got the complete resection. So for low-grade gliomas, we know that it's really important. But there is an evolving body of evidence to suggest that resection extent is associated with survival. And then again, this has to be taken in the context, like the lady I mentioned that I was consulted on yesterday. What's the KPS? What's their age? What's their functional status? So as I mentioned, there's not been a prospective randomized study, but there have been a few level 2 studies of retrospective, and probably the most interesting one is one where this guy, Stummer in Germany, who was one of the pioneers of the 5-ALA that I mentioned earlier, they did a study to see could you get a better resection of people if you gave them 5-ALA and then resected their tumor. And they showed if you did a glioblastoma resection with 5-ALA, 65% of the time you got a complete resection. There's no residual on post-op MRI, compared to 35% in the non-5-ALA group. What was interesting is that there was a dramatic difference in the post-op progression-free survival. There was double the progression-free survival in those who'd had a complete resection based on the imaging. So, and that sort of fits in with some other studies by other groups, Gorlia et al. And basically the bottom line is when people have done a biopsy and retrospective studies, the median survival's in the 9 to 7 months range, whereas with complete resection, it's double that basically. So the nihilist professor I had in med school who said, oh, they're 75 years old and they got a GBM, just do a biopsy and send them home. That doesn't fly anymore based on data. A summary by Mitch Berger, who I used to work with, and Nader Sinai, who came here a couple weeks ago to give a talk, looking at all the data out there showed, there is improvement in survival for glioblastoma. Unfortunately, this line is really low, 18 months. You probably increased it a few months by a more aggressive resection. But as you go to grade 3 and grade 2 tumors, you see that there's more and more of a benefit. So this talk isn't really as much on low-grade gliomas, but if I do see a 25-year-old with a right frontal low-grade glioma, non-enhancing, I just like, let's get it out now. And I do see people that still come through clinic who have been seen by somewhere else and like, let's just watch this. Like, we're not going to watch this. We're going to get it out if we can do it safely. Ray Sawaya, who was at, who recently retired at MD Anderson, was super aggressive, and he kind of invented this concept of super beyond gross total, which means you get the enhancing part and then the flare signal stuff around it. And when he did that, he even bumped up median survival. And I won't go into detail, but just one other piece of evidence that if we can get all the infiltrating tumor that you don't even see on gadolinium, that is probably helpful too. So moving right along, we get the tumor out. Pathology, I'm not going to belabor this because no one gets, well, I shouldn't say this, is Megan around? I don't know. Pathology kind of is its own universe, but you know, this was the state of the art 10 years ago when Patrick Nguyen and Santosh Kesari, two of my colleagues, wrote a review in New England Journal. You would get a GBM and like, hey, there's pseudopalisadic necrosis, there's hypervascularity, there's Ki67 is elevated, everything's EGFR positive. That's the state of the art of the pathology. Now the pathology has become a complete molecular entity. Now we basically do, the first thing we want to know is if a tumor comes out, let's say it's a GBM, is it IDH1 wild type or mutant? If it's IDH mutant, we know it's a different beast than this guy. So this immediately divides glioblastomas into two. These are the ones that usually are more or less aggressive. And then there are other markers that divide them into either astrocytic or oligodendroglial. So let's say you have something under the microscope that looks like a grade 2 or 3. First, you want to know if it's IDH mutated. Then you want to know if it's got ATRX, which is a nuclear marker, and if it has retained it, it's an astrocytoma. If it's got loss of that, and it's got loss of 1p19q, then it's an oligodendroglioma. We now know there's a third kind of type of tumor that's associated with midline gliomas called H3K27 mutant. It's a diffuse midline glioma, and it's got its own distinct biology as well. So instead of coming in and having the pathologist say, hey, look, there's like some Rosenthal fibers or there's some necrosis, they're going to do this. They're going to take the tumor, they're going to do histopathology, they're going to see, is it mutated for IDH1? Yes. Is it nuclear HRA loss? No. It goes to diffuse anaplastic astrocytoma. Is it wild type IDH mutant, which is the ones we see most of the time, which is bad? Yes. Is that loss? No. Then it goes into these categories, and if 1p19q is co-deleted, it goes into the oligodendroglial. So that's how the diagnoses are made. So you get the diagnosis, you have glioblastoma or high-grade glioma. What is the next step? Well, this kind of summarizes standard of care. You come in, have surgery. You have maximal resection. You get steroids. You get anti-epileptic drugs if appropriate. Then you get post-op treatment for DVT. I don't know if that's in there. Then after 3 or 4 weeks or a month or so, up to 6 weeks, you start radiation. You have radiation 5 days a week because radiation doesn't work on the weekends. So we just do it on weekdays. And you go for 6 weeks, and then you get temozolomide during that time. Then you take a month off, and then you get temozolomide 5 days at the beginning of each month. And this goes 6 cycles. Typically, we go for a year here in the US. I think this was a European. And that's sort of illustrated on here. But you also have to take, this is the NCCN guidelines, but you also have to take into account, what if this person is horribly debilitated and they're over 70? Well, you might just do a short course of radiation or palliative care if they're really debilitated. But essentially, it's the same thing that I just mentioned, standard radiation or poor performance, you might do short course radiation, palliative care, and then you get an MRI every 2 months or so after that and follow them. The radiation is standard external beam. It's not any of these super fancy things, although we do use IMRT some, but basically you want to treat the tumor residual plus a couple of centimeters around that up to 60 gray total. Chemotherapy was basically non-beneficial to patients until a study came out in 2005, which was a breakthrough, quote unquote. I don't consider it a breakthrough because, I mean, it was really, I guess, but you know, the median survival went from about 14 months to about 16 months. And that was when temozolomide was studied. And it turns out that, again, this is based on the molecular classification of the tumor. 100% of that benefit to those patients was due to the fact that the people that survived longer had a methylated MGMT promoter. So what does that mean? So this drug, temozolomide, puts a methyl group on guanine on the DNA, and that will clog up DNA repair, and that will cause a cell to die. If something comes along and removes that methyl group, then that chemo doesn't work. So what happens is if you're unmethylated for this enzyme that can remove that molecule, then you'll have a protein that'll come on and just pull off that modification, and you will not respond to the chemo. If you have that methylator phenotype, especially as I mentioned early on, the patients with the IDH1 mutations who get methylated everywhere, they will often have a methylated promoter, so they don't make this protein which inactivates the chemo. So these patients will therefore respond better to the chemo. So if you happen to be in that 30% of glioblastoma patients who has methylated promoter region for your MGMT protein, then you do dramatically better. You're on this curve compared to everybody else. So that's why temozolomide works. Unfortunately, that means we treat 2/3 of our patients with temozolomide, which causes a lot of DNA mutations, knowing that they get basically no benefit from it. So there's a lot of neuro-oncologists now who are questioning, should we be treating these patients that are unmethylated at all with temozolomide?
What percentage of patients are methylated?
About 33% are methylated. There are some other kind of, yes?
Why can't you just do the genetic analysis ahead of time before you start the temozolomide?
Well, there's a lot of rational people saying what we do. We know we have patients that are unmethylated that get temozolomide. I think it's, you know, the oncologists feel that maybe there are a few of those that might respond, but I think when you really drill down, it looks like very few people that have unmethylated promoter will respond. So there's a lot of people now arguing we shouldn't be treating these people with temozolomide because it makes their tumor hypermutated and maybe even more aggressive. There are some other kind of unusual things that have come down the pipe out of the blue. For instance, alternating electrical fields. This is the Novacure device. You may have seen patients with shaved heads who wear these electrodes on their head, and this big battery thing causes electrical currents to go back and forth across the brain, and it screws up microtubules when the cells are in mitosis. And there's evidence that can prevent tumor growth. And a big prospective study showed, and it was stopped early because there was benefit to tumor treatment fields plus temozolomide compared to temozolomide alone. And now this is FDA approved for upfront and recurrent glioblastoma. Some patients don't want to have their head shaved and have this, so but it is an option.
How often do you have to wear that?
All the time.
Constant?
Yeah.
Wow.
So unfortunately, we know that the tumors come back. And for a while, it was really difficult after Avastin or bevacizumab treatment to know, is this recurrence? Is this pseudoprogression? What is this? And so they had to change the whole criteria for determining if tumors recurred. Now there's something called the RANO criteria. And basically, it takes into account gadolinium enhancement, flare signal abnormality, whether they're on steroids, and the clinical status. And you put all these things together, And basically, if you have increased gadolinium enhancement and deteriorating clinical status and increased flare signal, that's considered recurrence. And when the patients have recurrence, as you probably know, recurrent glioblastoma is a bleak prognosis with a median survival of about 7 to 9 months. I won't go through this extensively, but basically we have the same things at our disposal to do for these patients. So when they get to this point where there's recurrent disease, you can have repeat surgery. Sometimes that has helped. And if they're methylated, we might consider giving them temozolomide again. If they're unmethylated, try these other things, bevacizumab. But bevacizumab does have side effects, and it's not a panacea. It does not improve survival. It does help with some of the bulky swelling associated with these tumors. But neuro-oncologists love it because it does symptomatically help patients. And so I think if you're going to decline like this without it, you may do better and then decline at the end, but you do not have improved overall survival with bevacizumab. I'd like to just kind of go really rapidly through the last bunch of slides. Well, this is just a picture to show that you may think you're controlling the tumor if you give bevacizumab because there's no tumor enhancement. But as I mentioned, it blocks the gadolinium leakage, but here's the flare signal of that patient. As you can see, the tumor's growing despite being on bevacizumab. About 15 or 10 years ago, we had high hopes, and this is from a review article in the New England Journal, that all these signaling pathways that we're so smart to figure out, and we can do Foundation 1, we can figure out EGFRs amplified, that now we're going to be able to cure this disease. So everything that you see here has been targeted with one drug or another, and the long story is that all these things have been tried, and that only rarely have there been sustained survival results. Here's some early studies where they, for instance, treated this patient with an EGFR and mTOR inhibitor, and it's like tumor goes away, but then a couple months later, boom. And that's because these tumors have multiple, it's like whack-a-mole. You knock out the EGFR pathway, and then another pathway drives a tumor. And you take out this and add this, and so it's become quite difficult. And this is just kind of a summary of all the different growth factors, amplifications, cell cycle pathway inhibitors that have been tried for glioblastoma. But I had the fortune of being involved in a spore study section for brain tumor just recently, and there are actually some things coming down the pike that I think are that may improve survival for a significant number of patients. I personally believe the future of the treatment of this disease is going to be figuring out what's going on in the immune system and modulating that and getting an immune response. This is 2 years ago, all the different clinical trials that were in phase 3 that had some type of immunological component. For instance, I think this, there were the PD-1 inhibitors you hear about on commercials on TV. We were trying those with standard treatment for unmethylated glioblastomas. There's companies that are making antibodies and vaccines to some of the tumor stem cell markers. And all of these things are being tried, and there have been some limited promising results. Checkpoint inhibitors I mentioned are being tested, and we haven't had any successes yet, just giving like a PD-1 or CTLA-4 inhibitor plus standard of care. But a paper in Nature came out recently by a group at Harvard that showed if you identify specific mutations in an individual patient's tumor and you vaccinate for those plus a checkpoint inhibitor, you may get a significant anti-tumor response. So we need to turn on those weak, pathetic T cells that are not functioning and retarget them to the tumor. One attempt to do this is to leverage the concept that tumor cells have lost their ability to fight intrinsic viral infection. So that makes them uniquely susceptible to viral infections. So people have come out with viral therapies where you inject a virus, it preferentially and uniquely infects the tumor but not the adjacent brain. And if that virus encodes for a pre-drug or toxic molecule or just causes an immune response, that may have benefit. And that was highly touted on 60 Minutes, the polio vaccine at Duke, but that hasn't totally panned out. But that concept is interesting. And this drug here, for instance, is a live retrovirus that encodes a pro-enzyme that converts 5-FU to 5-FC. So you infect the tumor with this retrovirus, it infects the tumor cells, then you give 5-FU, and it kills any of the tumor cells that are infected. And there have been some interesting results. So some of these therapeutic approaches are quite innovative. So well, the last thing I'll mention along those lines is something that I'm highly involved with. Is my lab's been studying cytomegalovirus, and we discovered that it seems to be highly associated with glioblastomas. And so John Sampson and Dwayne Mitchell from Duke and I started working together back in the early 2000s, and they've developed vaccines against some of the proteins of this virus CMV, which I believe infects glioblastomas. And they've actually had some amazing survival results in a couple of phase 1 studies, and now they've expanded to phase 2. And this study with 11 patients, they vaccinated them against one of the viral proteins that we see in the tumors, and the patients against historical controls had a median survival of about over 3 years, and I think a third or more of the patients are still alive at 6 or 7 years, which is quite striking. So this seems to be somewhat promising. And I think that if we can really elucidate the role of this virus in these tumors more, we may even get much better vaccine targets and be able to ramp up this result. So general guidelines. Patient has a recurrent glioblastoma. I always say stay close to home. We get people that come and say, should I fly to Duke? Should I do this? It's kind of a bleak prognosis. There's not a whole lot available, but my recommendation is if you find an immunotherapy trial, especially if it's not a single-arm trial, that's probably good. And if you can get on an innovative clinical trial, that's what I recommend. But still, we're not at a point where there's, patients come to us and they seem to think, well, if I just can get on the web and find that one study that's actually working, and you probably know what it is, and we're like, if I knew, then everybody I have would go there. So my predictions, this is the last slide. I think the imaging techniques will be evolving and will help us in predicting the therapeutic response of targeted therapies. Some of this stuff coming down the line, especially for like the IDH1 mutated tumors, we may be able to see if we're treating these tumors, if that toxic metabolite 2-hydroxyglutarate is actually going away. We may have metabolic ideas of what's going on in the tumor. So that's where the imaging is going. I think more aggressive surgery with some of these molecular fluorescent markers like 5-ALA may improve our ability to take tumor out better, but tumor surgery is not going to cure this disease, obviously. I think understanding these molecular pathways and leveraging them, maybe leveraging drugs that knock out IDH1 metabolic pathways, that's coming down the pike. These things are going to be coming out. I think that there are new therapies that are going to be coming out soon that will induce the intrinsic immune activation of the tumor cells and make them more visible to the immune system, which will allow them to respond better to the checkpoint inhibitor drugs like PD-1 and CTLA-4 inhibitors, to make these tumor cells that are invisible to the immune system, visible, and then maybe your immune system can take them out. The virotherapies are quite interesting, but I think in the long run, my money is on immunological strategies, as I was mentioning. Turn on the immune response, turn up the T cells, identify molecular properties of the tumor. Maybe they're viral proteins like CMV that we can really vaccinate strongly against and have the immune system come in and take care of the tumor. Because in the final analysis, this is a diffuse infiltrative tumor. No targeted treatment in terms of anatomical targeting is going to work. The patient I just saw yesterday has multifocal glioblastoma all over the brain. Unless you can have something like the immune system go after that, you're not going to cure it. So thank you very much for your time, and I'll be happy to answer any questions. Dave.
But on the standard resections, some sometimes you get a subtotal resection because you didn't appreciate where the tumor was at the time. Certain other times, the tumors are in deep portions and you're never going to get a good resection. So they kind of pre-selected to be a little bit more nasty. But what about if there's such a powerful effect of getting the whole tumor out? What about the concept that after surgery, you see some left behind? Most people are reluctant to go back in and take the last bit. What about zapping it with focused ultrasound or something?
You know, I think
Radiation, everybody says, well, let's let the radiation take the, but obviously it doesn't because in both arms of the patient's got radiation.
right.
One got something.
So you're saying something that would absolutely obliterate the obvious tumor. I mean, if you can't operate on it.
If there's some residual after surgery that you can appreciate.
Yeah, I think that that's just going to be actually probably a cost-benefit analysis. You know, if it costs a lot to go back and zap that last half centimeter of tumor, and the benefit is not shown clearly be more than a month of survival, people might not advocate that. I don't know. Yes.
So just kind of a question about kind of the human or the animal models of oncology, of neuro-oncology. From the neurodegenerative standpoint, our animal models never quite work, you know, when it translates to humans. How good is it for oncology in terms of the mouse models with the different tumor suppressors and the oncology jobs that translate to humans?
So most people that are working in mouse models are now using syngeneic mouse models. So gliomas like GL261 is a mouse glioma. And that's pretty decent. There actually are good dog models. Dogs get spontaneous glioblastomas, and they highly seem to reproduce the biology and characteristics of humans. And UC Davis has a big center for that collaborates with UCSF, looking at using dogs for some of these studies. Yeah, you're right. There, you know, you can cure these tumors often in the sort of the classic skid mouse with a with a cell line implanted model. That does not really very accurately show what's going to happen in humans. But you really need the infiltrative tumors. You need a syngeneic mouse because the immune system's so critical. So that's where most of the work is being done now in mouse models. Thank you all very much.